Hello, everyone, and welcome back. In the next half an hour or so, we're going to get through a few cases. Not necessarily the most challenging, but everyday cases. Initially, we had hoped to do it as, quiz with connecting to your mobile phones, but that didn't happen. So anyways, we'll get through this just as case after case. But we'll start with this particular quote. My favorite author, Mark Twain, he has said this: I have never let my schooling interfere with my education. Which means after you're done with your med school, your residency, and all the formal schooling, continue learning. That's the only way you'll educate yourself. Okay? So, here we go. Let's look at our first case. We have already seen this case, but nonetheless, 23-year-old with new onset palpable lump, inferior left breast, well circumscribed, T2 hyperintense. What is the most probable diagnosis? On contrast enhanced sequences, rim enhancing mass, which gets subtracted completely, biopsy in keeping with triple negative breast cancer. These can look exactly like fibroadenomas, so remember, you have to biopsy them. Okay, next case, 44-year-old, increasing palpable lump in the right breast since 6 to 8 months. What is the most likely diagnosis? On the bilateral mammogram, excellent. Yeah, you can just shout out the answers. This is a fun session. Okay, so well circumscribed mass, and on ultrasound, it corresponds to this large hypoechoic solid mass with non-uniform cystic spaces. Ultrasound guided core biopsy was performed, and this was in keeping with a fibroadenoma. Okay, so these are a little bit of twists in the tail. Okay, is this concordant? It is really large. She's 44-year-old with new onset palpable lump. So eventually we send her for a surgical excision. She herself wanted a surgical excision. In this case, it continued to be a fibroadenoma. It was a cellular fibroadenoma though. Okay, next case. 27-year-old, 6 months postpartum, increasing palpable lump in the right breast. She's 6 months postpartum, and this is what the mass looked like. Well circumscribed. There are coarse calcifications within the mass. On ultrasound, it looks like a mixed echogenicity mass. Could it be a galactosele? Could it be something more? Yeah. So she had an existing fibroadenoma, and now this lesion was increasing, which was perceived to be a fibroadenoma. This was an increasing palpable lump. Eventually, she needed a mastectomy because it was almost occupying the entire right breast. This was a malignant phalloides tumor. Okay. Next case, 32-year-old, 3 months postpartum, increasing palpable lump in the right breast. We have tried to take similar clinical scenarios. Increasing palpable lump in the right breast. Ultrasound was performed which corresponded to this oval, heterogeneously hypoechoic mass. We were almost certain that we were dealing with a galactosele. So we did a unilateral single view mammogram on which we saw this layering. Now, this was indeed in keeping with a galactosele, but many a times you may not see this distinct layering within a galactosele. If you're in doubt, you can just stick in a needle and aspirate it. You'll see milky fluid in those aspirates. Okay? Next case, 70-year-old. This lady has had a left mastectomy for breast cancer in 2014. Now she complains of new onset palpable lump at the left mastectomy site since 2 weeks. This was not there before. She's absolutely certain. She also has a very strong family history of breast cancer. She says that she's never tested for BRCA mutation or genetic mutation. Her right mammogram is pristine, fatty replaced, but at the scar site corresponding to the area of new onset palpable concern, this is what we see, an irregular hypoechoic solid mass. Yes? Correct. Although she perceived it as a new onset palpable lump, we suspected we may be dealing with fat necrosis. So instead of going ahead with a biopsy, we did a limited spot magnification view with tomosynthesis at the scar site. On the tomosynthesis, what do we see? We see central fat, which is pathognomonic of fat necrosis. So fat necrosis can have a very sinister appearance on ultrasound. Sometimes a simple maneuver like correlating with the mammogram can help us make the diagnosis. Okay. Yeah, we could, but before aspiration, like we try not to do FNACs for any breast lesions anymore. If we are suspicious, we go ahead with a core biopsy. This was a tiebreaker for us, the tomosynthesis, the mammo image or the tomosynthesis, a tiebreaker whether we should stick in a needle or not stick in a needle. So since we saw fat, which is clearly seen on mammograms, therefore we didn't need to aspirate at all or do a biopsy at all. Okay, next case, again, sorry. It may. Yeah, no problem. It will still tell you. Yeah, you will see fat within the lesion. Yeah. So next case, 70-year-old left mastectomy for breast cancer in 2014. Now she complains of new onset palpable lump at the left mastectomy site. Exactly similar history. Okay, since 2 weeks. Same case, sorry. Next case is 77-year-old right mastectomy for breast cancer in 2005. New onset palpable lump at the mastectomy site since 2 weeks. This is her left mammogram, which is the uninvolved side, and this is her right mastectomy site. What is the most likely diagnosis? In the right mastectomy site, we are seeing this irregular hypoechoic solid mass. Malignant, that's correct. You see the difference between what a fat necrosis related lump versus a recurrence related mass looks like. Now, is there anything else you notice? Left breast also, we are seeing these suspicious lymph nodes, and we are also seeing some microcalcifications. Is there an architectural distortion? Okay, so these were the questions we had in mind. And retracted nipple, skin thickening. So we did an ultrasound for the site. On ultrasound at the right mastectomy site, in addition to the irregular hypoechoic solid mass with angulations and microlobulations along the margin, we also saw enlarged hypoechoic lymph nodes with partial loss of fatty hilum, suspicious. Okay, but also in the left breast, we saw this irregular hypoechoic solid mass. So there was a contralateral malignancy on the left, local tumor recurrence on the right, and bilateral metastatic lymphadenopathy. Everything that bad was possibly could happen had happened in this case. Okay. Next case, 55-year-old complains of right nipple swelling since 3 weeks. So she's pretty certain that her right nipple was not like this before, and now she's feeling a swelling in the right nipple. Correct. There are some microcalcifications. They are not in the breast, but they are just in the nipple. Yeah. So when we did the spot magnification views, because we were concerned that we may be just seeing the tip of the iceberg, we continue to see the microcalcifications just within the nipple. The breast does not show as many any microcalcifications at all. On ultrasound of the nipple, no discrete mass is identified. What is the most likely diagnosis? This was actually in keeping with a nipple adenoma. So nipple adenomas are supposed to be variants of intraductal papillomas. Okay, this was not like a Paget's disease of the nipple with DCIS. There was no crusting, scaling of the nipple, just left nipple swelling. Okay, and typically with left nipple swelling, you can see a discrete mass within the nipple. In this case, it is still small probably, therefore we were not seeing a discrete mass in the nipple. She underwent excision, and on the excision, diagnosis was nipple adenoma. These are variants of intraductal papillomas, the duct which reaches right up to the nipple, the papillomas develop within that. 32-year-old complains of right nipple crusting and bleeding since 6 to 8 months. So in the right breast, on dynamic post-contrast sequences, we see asymmetric non-mass enhancement predominantly involving the inferior hemisphere of the right breast with marked skin thickening. What are we dealing with? There is also right nipple crusting and bleeding since 6 to 8 months. This is what it looks like. What are we dealing with? That's right, Paget's disease of the nipple. You notice the difference between what a nipple adenoma, there was no crusting scaling here. There is clear-cut crusting, scaling, and all this was multicentric DCIS in the right breast. Patient eventually underwent a mastectomy. Next case, 32-year-old with right nip, this is the same case, sorry. 44-year-old, she comes for a routine screening. What is the most likely diagnosis? Hamartoma. Good thought. Correct. That's right. Breast within breast. Bingo. Okay. So on ultrasound, we saw this. Okay. So ultrasound can actually be sometimes very confusing when you're dealing with the hamartoma, because the breast tissue, yeah, we don't see the capsule clearly. The breast tissue, normal breast tissue can cause shadowing. So mammogram is the diagnostic test. Yeah, malignancies, fibroadenomas, cyst, everything can happen inside a fibroadenoma because after all it is breast tissue. But the primary diagnosis here was a hamartoma. On tomosynthesis, notice how you see a nice clean capsule. Yeah, so on the tomo we saw this capsule, and this is just normal breast tissue within that capsule. And this is indeed in keeping with a hamartoma. Okay, next case. 63-year-old postmenopausal complains of new onset, spontaneous bloody left nipple discharge. What are we dealing with? It's a nice fatty mammogram, and what do we see? We need MRI. No, but there is some finding on the mammogram also. There is a global asymmetry, yeah, that we see on the mammogram. Everybody notices this pattern, like, you know, this linear pattern with tiny lesions and these ducts that are going all the way. So that looked concerning. Also, ultrasound was performed. Okay. On ultrasound, we did see dilated ducts. On tomosynthesis, the ductal pattern is far more clearly seen. Those dilated ducts in the left retroareolar region extending all the way. But the patient did not want to undergo a MRI. Therefore, ultrasound-guided biopsy was performed, which was in keeping with intraductal papillomatosis with DCIS. Eventually, she underwent a mastectomy. She didn't want to undergo a lumpectomy, but she didn't want to live with it. Yes. In this case, a true-cut biopsy was done. Ultrasound-guided core biopsy was done. The dilated ducts and those tiny intraductal lesions. But when we do a core biopsy, sometimes in these cases, normally when there is a speculated mass, we will obtain 4 core biopsy samples and we'll stop. In such cases where we have a doubt of underestimation, yeah, we go for 6, 7, something like that. Yeah. Again, 32-year-old routine screening. She has undergone breast augmentation surgery some 10 years ago. And this is what we have on the bilateral mammogram. She has bilateral retropectoral silicone implants. Is there any abnormality that you see on the implants? Left side you see high density, okay, in the breast. Any problem in the implant? Yeah, okay. So in the right breast implant, we see a sign. What is that sign? subcapsular line sign. Does everybody notice this line right here? Yeah. Intracapsular rupture. Yeah, intracapsular. When there is an extracapsular rupture, you will invariably see little blebs of silicone in the breast tissue. That has not happened here. So what happens is, when a breast implant is deployed within the breast, whether it is retropectoral or whether it is anterior to the pectoral muscle, there is a fibrous capsule, normal body reaction, fibrous capsule that the body forms around the implant. So it automatically, nature has made this so that the implant gets encapsulated within the fibrous capsule. Therefore, even when there is an implant rupture, intracapsular implant rupture, it still remains contained within the fibrous capsule or the false capsule. It is only when the fibrous capsule also gets ruptured that we'll see silicone outside of the capsule. So MRI was done. MRI is the most sensitive test for assessment of breast implants. And on the MRI also, we see this, what we call the salad dressing sign. Okay, so there are a few signs, and then we also see the subcapsular line sign. Okay, so these are some of the signs that we go by to diagnose intracapsular rupture. So that was the finding here: right breast intercapsular rupture, left breast was intact, and bilateral breast were within normal limits. Yeah, this is another thing that we come across. Patients who have implants, they often do not want to get a mammogram done. Okay, they will come to us and say, I do not want a mammogram, just do a MRI for me. The technologist will typically call us and say that, doctor, there is an implant patient here, should I do the implant protocol? So one has to understand, implant protocol is for assessment of implants. We do not give contrast when we do assessment of implants. But this patient has specifically come not for assessment of implant, but for screening of breast. Then you have to give contrast, because without dynamic post-contrast sequences, we cannot make an assessment of the breast tissue. We wouldn't know whether there is a cancer or a precancerous lesion in the breast. So that is one point we want to remember. Why are we doing this study? If it is for assessment of implant, or is it assessment of breast tissue? Okay. Next case, 46-year-old comes for a routine screening mammogram. This is what we see on the mammogram: CC and MLO projection. Is there any abnormality seen? Right breast asymmetry. Okay. Anything else? Yeah. Yes, that's right, because it's a denser mammogram, right? It becomes harder. There are some microcalcifications in the lower outer quadrant of the left breast, but they are associated with a mass there, okay? So when we do spot magnification views, we are able to better assess microcalcifications in any region. We often get asked, with digital mammography and the ability to do zooming on the screen, do you still need spot magnification views? Sometimes when they are regional or segmental, we may not need it. But smaller clusters of grouped pleomorphic microcalcifications, we still continue to do CC and ML views. There are two reasons for that. One is, when we do assessment of microcalcifications, we obtain CC view and ML view. It is not MLO. That helps to assess for layering microcalcifications when we do a straight lateral view. And the third and the second point is, it is a magnification view, okay? There is a standoff paddle and there is a smaller focal spot to increase the resolution, which helps for morphologic assessment of the microcalcifications, okay? So whether they are dots and dashes, V's and Y's, linear, pleomorphic, that assessment can be best done with your CC and ML projection. Based on this, we know that these are definitely pleomorphic microcalcifications in a segmental distribution. Stereotactic vacuum biopsy was performed, which was in keeping with DCIS. Next case. This is a 45-year-old who comes for a routine screening mammogram. Yeah. So What is the most likely diagnosis? Again, we have, correct, that's right. So popcorn calcifications, they are slightly heterogeneous, but they are slightly coarse. Sometimes we worry about coarse heterogeneous calcifications. Are we dealing with a malignancy? But sometimes just comparing it to the previous, if you see a fibroadenoma in the same spot and you start seeing coarse calcifications in that spot, it kind of helps us to make the diagnosis. Having said that, multiple times, many times, we will actually biopsy these calcifications. We will not assume that they are coarse calcifications with the involuting fibroadenoma, because while the process of involution starts, there can be an overlap in the imaging features between pleomorphic or heterogeneous coarse calcifications related to a malignancy versus coarse calcifications in an involuting fibroadenoma. Okay, next case. Yeah, that's the same case. So 59-year-old with new onset palpable lump in the left breast. What are we seeing? Ah, right. So don't get fooled by these coarse calcifications. Sometimes, yeah, there can be a coarse calcification from a fibroadenoma which was there before. But how do we know that a cancer won't develop in a spot adjacent to it? It can easily develop in a spot adjacent to it, right? So we did spot magnification view here, not a spot magnification view, but a cone compression view. And what do we see? We did see the mass, and we did see some irregularity of the margin there. Ultrasound correlation, we definitely see shadowing, dense shadowing corresponding to the coarse calcification, but also there is an irregular hypoechoic mass adjacent to it, which was biopsied and which was in keeping with a invasive duct carcinoma. So there is an old calcified fibroadenoma, and adjacent to the old calcified fibroadenoma, we have an invasive duct carcinoma. So treat every case as an individual. Don't just assume, because benign and malignant pathologies can coexist. Okay, next case. 55-year-old with new onset left breast swelling and pain since 3 to 4 days. She's in so much pain that she says that she cannot have a mammogram no matter what. And she's 55. When a left breast ultrasound is done, we see that there is redness involving the skin. Yeah, there is this what looks like a hypoechoic mass, but also there is this prominent lymph node, and there is skin thickening. We are all worried that are we dealing with an inflammatory breast cancer? She's not allowing us to do a mammogram, so we decide that we'll schedule her for an MRI. In the meantime, because there is redness of skin, what is done is she's prescribed antibiotics and anti-inflammatories, and she's sent back home. She's seen by a surgeon at the clinic, and she's sent back home. Okay, patient is also a little bit slow in her thinking. Okay, she's not a very sharp, active person. She's smart but slow. So she goes home, and she's asked to return 1 week later, but she does not come back. She comes back a few days later, which is almost 2 weeks. And what do we see? Yeah, 15 days later, this is what we have. This is not an angiosarcoma. This was all breast abscess. And yeah, this was all breast abscess. We don't know, I don't remember now whether she was diabetic or not, but this was skin necrosis. This was all skin necrosis. Like I said, the patient was slow in her thinking, and she was living alone. So there was no way that she decided that she was in pain, she wasn't feeling well, she'll not go to the doctor yet, she'll keep taking her antibiotics. Clearly, she was not responding to antibiotics. Eventually, a drainage was done for her. This was all indeed abscess, all abscess. But because the abscess was so huge, it led to skin necrosis. So beware, sometimes the most indolent of diagnosis can give so much trouble. Left breast abscess with skin necrosis. Okay, so I shall stop right here, and I thank you for your kind attention. Thank you very much.